experience under 21st Century Cures Act provision against information blocking using HINTS data. Dr. Suma Mukhopadhyay is currently an assistant professor of computer information system at NCCU at School of Business. She has a PhD degree in management information system and electrical engineering degree. Dr. Mukhopadhyay has several years of experience in teaching in the field of cybersecurity, management information systems. Along with teaching, she's an active and accomplished researcher. Her research interests include security and privacy of information systems, consumer adaptation of AI and other technologies, and health informatics, including providers' role in patient use of portals. She has published extensively in leading peer-reviewed journals, including and also presented many in top information system conferences. She was honored with a Michael P. Johnson Endowed Professorship by School of Business at NCCU in recognition of her scholarly activities. Dr. Basak is from UNC Chapel. He's a socio-behavioral researcher and applied statistician at UNC Chapel Department of Urology. Currently, he works with multiple clinician researchers spanning the broad spectrum domain of genitourinary oncology. His research interests lie in the intersection of health behaviors and decision-making, treatment, medication use and outcomes, health informatics, and applied statistical methods. Dr. Basak has extensively published in top peer-reviewed journals, including JAMA and Cancer and many other top journals. He's also editorial board member in many of these journals. Dr. Basak has a PhD in pharmaceutical outcomes, policy, and marketing from University of Mississippi, and MS in statistics from UNC Chapel. Welcome.
Hey, good evening, everybody. Hope you all are well. So today we are going to talk about, our topic is insights into patient experience under the 21st Century Cares Act provision against information blocking and using HINTS data. So Dr. Damodaran already have introduced me. So I just want to jump to the presentation. So I just want to start with some use cases. So let's talk about Emma. So Emma is 35 years old, teacher. She's fit and healthy. And today, 29th October, she went to the doctor for, some mammogram thing, like routine wellness checkup in the morning. And right now in the evening, she got some results in her online portal. Those are the images and she cannot understand those, but she, with her intelligence, she can understand there is something that is not very usual. So there may be a cyst or something like that, but she is, very shocked, very upset, but she cannot contact with the doctor, or the doctor's office says like doctor is not available, something like that. But remember, today is 29th October. So why I'm talking about 29th October? So we know that 31st October, 30th October, 31st October is the last date for that open enrollment thing. And Emma and her husband, they are thinking like what to do, because there is something unusual that may be bad. They are unable to, interpret the result correctly or, in the full extent. And they cannot contact the doctor at this moment. So they have the test results, but they don't have the correct, or you can say like detailed interpretation. So they choose to be in the safe side. They choose to go with some more expensive insurance coverage that cover cancers and other diseases. And because they just think if something bad will happen, then what to do. So maybe in the next week, she will be able to connect with the healthcare provider and get a note from there. And healthcare provider may say, and it happened, if you have some knowledge about this, we know like maybe that is only some very benign or cyst that is nothing to do. Emma didn't have mammogram for a long time, so it is not serious. But the conclusion is she is going to pay that extra money throughout the year because there is a gap between the interpretation of the result and also the availability of the result they have. So that is something we want to we are going to discuss in this presentation. And thank you so much for this opportunity. I felt that this is very important for us. So another case, maybe 55 years old, living alone, got an incidental severe kidney function issue when visited for chronic stomach upsets. So that person may also be very panicked. Another case, 65 years old grandpa got diabetes. Grandpa knew that there is his father, mother, whoever, they had it's genetic, they have diabetes, but the grandpa is panicked. Maybe next week the grandpa may know from the provider's explanation that it is kind of usual, what we call that HB1C, that is like little bit increased from the from the level. So there is a panic. So we are going to talk about that in this presentation. So basically, we are going to talk about mainly about information blocking prohibition. So before that, we all know that the rapid digitization of healthcare has transformed the ways patients interact with their medical information, the medical service providers, specifically after COVID. So many people learn to access and use the online portals, whether they understand it fully or not, but they have that options to access the portals. So these portals enable the patients to review their test results, medications, connecting with the doctors, and most important, making informed decisions. That is important. But in this context, we are going to talk about the 21st Century Cures Act final rule. So in that rule that is already enacted in April 2021, in that rule, there are some components. The first component is information blocking prohibition. So what is information blocking prohibition? This rule mandates that nearly all test results, medication list, and clinical notes should be immediately accessible electronically to the patients and their designated care partners. So this is one of the main component in the information block in the 21st Century Cures Act. There are some other components too. For example, there is interoperability. So how the systems, like how the systems, they can talk with each other seamlessly. So we are not going to talk about interoperability today. We are going to focus on information blocking prohibition. So prior to the Cures Act final rule, health systems commonly delayed or withheld certain results, a practice collectively defined as information blocking. So after the final rule is in effect, that is ended. So the discretionary withholding of the information is ended. Next, we are going to talk. So we are mainly going to talk about the information blocking prohibition from the Cures Act. So what are the motivations for this provision? So motivations are, the first and most important is obviously the patient empowerment. Patients, from the prior research, from the prior surveys, we know that patients, they always want their all their test results and health information related thing immediately available in the portal. So they want all this information in the portal. So patient empowerment and engagement is important, and if they have very transparent and immediate data, that is obviously possible. Safety improvements, that is the second motivation. So safety improvements, if immediate follow-up is needed, if immediate some follow-up test is needed, something like that. So safety improvement is the second one. Standardization of access, that means this, based on this rule or based on this act, standardization of accessing all these results or these test related results will be increased. And the last one is it is helping to shift the whole thing toward the patient-centered care. So that is also important. Patient autonomy, the transparency of the result, the patient participation. So all these are important. So all these are the motivation of this information blocking prohibition or IBP. Now, what do the patients think? As I said, the prior studies, they mentioned that always the patients, they want unrestricted access to their healthcare record. So by legislating the immediate access, policymakers intended to empower the patients, but also there are some exceptions that we can talk about. So for example, if those test results or informations are harmful for the patients, for example, the patient is suicidal, so the provider or the doctor may not want to reveal everything to that patient. There are some other exceptions, security and privacy related exceptions. If the patient didn't sign the HIPAA authorized form, then that is related to privacy. So the test result may not be revealed to the patient. Then there is the security related problem, security related exceptions, and also healthcare IT providers, or if they have any feasibility related problems, maybe there is an outage, server is down or something like that. So all these are other exceptions, but mainly the main aim is to reveal everything, all the test results immediately to the patients. So what are some pros and cons, what the literature is saying about the pros and cons of the IBP or information blocking prohibition? The pros or the advantages obviously are increased patient engagement. So if they know like this is the test result, and if they have any questions, so when I'm talking about the immediate release of the test results, as I was telling about, or as I was giving the example, so other or the providers, they may not make or they may not create a note before the patient already view the test results. So the pros are the increased patient engagement. So even before any interaction with the providers, the patient may do some research or may have some question. They can prepare some questions, so that is increased patient engagement. Improved patient-clinician communication. So if the patient already know that this is the test result and I have this question and what is this and what is that, what I need to do. So that is that enhance the patient-clinician communication. Patient safety enhancements, as I told before, like it prevent the missed follow-ups, support for patient autonomy, that is very, very important. So the patient has all the control to schedule something, facilitate their self-directed, like the management of the like time and what they are going to do, their health literacy, everything. So support for patient autonomy. The next advantage is potential psychological benefits. So sometimes if the disease is like if it is a low risk test, so if the patient get a good result, obviously that is psychologically they will be relieved. And doubling of patient initiated message. So patient may send messages to the providers. I know like from the provider's perspective, it may be like sometimes difficult to handle all those messages, answering the questions. But from the patient perspective, it is good that they can get the test results and they can initiate the messaging, they can ask questions and all. Now, the next thing, obviously, with advantages, it also has some disadvantages or concerns. I should say it is a concern. So what is the main concern? The main concern is obviously the emotional distress and or worry. So emotional distress means when, as I explained at the very beginning, if I get the test result that is kind of, I don't understand, maybe it is negative or something like that. So if it is abnormal, so the patient may not understand or interpret whether that abnormality is very severe or it is not that severe, but always any abnormal test results, always we know, like we noticed, like when there is any abnormality in the test result, there is some indication with red or something like that in the test result. So abnormal test result may increase the distress, the emotional distress. The second one is sensitive diagnosis. So that is also a problem. So if it is related to Alzheimer, if it is related to cancer or fatal miscarriage, maybe that can create like very much emotional distress. Third one is gender difference. So the study showed like the female or the women, they reported higher anxiety than men when receiving the results, test results in Alzheimer's, cancers, or other kind of genetic tests. So that is the one and very important, first or very important concern, that is emotional stress and emotional distress and worry. The second one is interpretation of the test result, interpretation challenge and communication gaps. So portals often lack of guidance or context to interpret sensitive findings, potentially leading to distress. And also sometimes if the patient find like a good test result, he is kind of okay, everything is fine. But if it is like a bad or negative or something unusual, then the patient want to ask like immediately some questions to the providers. They cannot interpret the test results, so there is interpretation challenge and communication gaps and all these things. The third concern is from the from the doctor side or from the provider side. So their concern and the impact on their workflow. So doctors, they think like many patients, they cannot understand the test results, and that may increase the anxiety in the patients, and that is actually doing bad to the patient. So higher patient anxiety and increased complaints. And another thing is institutional preparedness. That is also important from the provider's perspective. So these are some concerns related to the information blocking prohibition. Now, what are some possible tools, implementation tools, or best practices that can mitigate these concerns? The first one is anticipatory guidance. So before the doctor send the patients for some test, they can do some sort of pre-counseling kind of thing. So they can like give more information to the patients that this means that or something like that. Another option may be the patient portal enhancement. So portal, actually these days we saw that the portals have the glossary of terms, the facts, and contextual information pages or links to some useful resources. So those are there. So that may be another tool to mitigate this concern. The third one may be automated notifications. So if the patients just don't want to view the result before the doctors view that result, then the patient may get some messages, okay, this is the test result, but the doctor didn't view it. So do you want to open it or something like that? So that is that the system may provide that option. The system may provide to the patients. Timing of the test results, maybe sometimes the test results are released at the end of the business day, maybe after 5 p.m. or around 5 p.m. So the patient cannot connect to anyone in the provider's office. That may be a problem, or that may even affect the patients like more negatively. So timing of result can be tuned. And obviously, there are more patient-centered customizations that may be adopted by the healthcare system. For example, type of results to release immediately, not all the results, maybe some of the results part of the results, modality of notification, whether it is email or messages. Another example is timing or batching of test results. So these things can be provided, these options, these are the options that can be provided by the portal or by the system, healthcare IT system, to mitigate some of these concerns. So what is the option? What is the best option that we found is the opt-in policy. So opt-in policy, it provides the feasibility of balancing transparency and transparency with emotional support. So there will be these options, what you want to do. The options are given to the patients. So integrate the patient's choice and reduce the clinician's burden. So allowing patients to choose whether to receive immediate release of specific results or not. So empirical studies found like opt-in policy may decrease the messaging volume from the patients, may decrease the patient's anxiety and make it more transparent. On the other hand, it is like kind of very interesting, and patients may anticipate their reactions. So for example, if a patient just have done some tests today, and maybe tomorrow there is a job interview or kind of something like that, so the patient may choose, okay, not to view the result, and the patient may not want that result in the portal maybe today or before the clinician or before the doctor provides the notes as associated with the test results. So that opt-in policy is kind of you can say the best solution for this for all of these concerns. So what are the gaps in the literature? So in the literature, actually there is not much studies that talked about this, considering a broad geographical region or considering a broad region. But there are like academic centers or hospitals or some pilot studies. So large scale implementation is important. And also patient characteristics were not tapped through the portals. Like after patients get the immediate results, immediate test results, what, like if they view it, what are the patient's characteristics, what is their health literacy, what is the demographic characteristics. So those were not tapped when the patient access their data. So we can work on that. We are investigating all those gaps in our study. So by the way, this study is still going on. So it's not like we get all the results and we have done all the analysis, but we are still working on this one. So after all this discussion, like in a nutshell, we can say that there is a tension among the three main things. There is a tension among three main things. The first one is patient empowerment. The second one is the autonomy. And the third one is legality or transparency. So if the results are provided, if the test results are provided to the patients immediately without the doctor's note of explanation or without the doctor's note or doctor's explanation, so that is good in the way that can maintain the transparency of the system, and also patient's autonomy. That means patient can control what he or she is going to do, or what will be the next steps or something like that. But at the same time, if that result is not good, so transparency and automation advance access, but they can undermine the empowerment, because patients, if the result is serious or they cannot interpret it, then it produces the confusion, distress, misinformed reaction. So that is why there is this tension among transparency or legality and autonomy and empowerment. So what are our research objectives? here are the three research objectives. State of diffusion of patient empowerment, that means assessing geographic diffusion by patient and system attributes. We are going to, I am going to discuss that. And state of patient engagement. So if they view that result, whether they viewed that result, if they are provided the result before the clinician's explanation or not, and whether they can understand their health literacy, whether they were able to understand understand the result if they don't have any explanation or note from the doctors. Okay, the data source is Haynes cycle 7. So Haynes cycles, Haynes data is by NCI, National Cancer Institute, and Haynes is Health Information National Trend Survey. So they are doing it for quite some time, and we for this study use the very latest data set, which is from cycle 7. That was released in 2024. So that is the data source. And for this presentation, we selected 3 questions in the past. So the questions were that we selected for this study from the HINTS data set, cycle 7. Those were in the past 12 months where you, that means the patients, were given the option to decide whether or not they wanted to receive test results before their healthcare provider could discuss the test results with them. So that is the first one. That is simply like whether they were given that option or not. The second one is, in the past 12 months, did you look at the test results made available to you through your online medical record? That means if they have given that option to get the test results before the clinician have seen those test results, whether they viewed that available test results or not. And the third one is kind of the nested question from the second question. So if they already view the test results, so how well they were able to understand or interpret the test results. So these 3 questions from the HINTS data we have selected for this presentation. So the first question was whether they were given that opt-in, like whether they're given the option to get the test result before the healthcare provider could discuss the test result with them or not. So the results shows, the next slides are about the results. So the result shows, the first slide shows the geographic disparity. So here are the 2 maps. So the left-hand side maps include everyone. That means we have total how many numbers? N equal to 6756. So these subjects are there. So all means everyone included. And in this slide, basically, we have divided them based on the geographic region. And these geographic regions are colored in different color. So for example, the red one is mountain, the orange one is Pacific, like that. And you can also notice that there are these numbers 30, 29, 34. So these are basically the percentages. That means the percentage of patients who got that option, who got that opt-in policy like enabled in their health portal. So that is included everybody. On the right side, the same map is there, but RUR means rural, only considering the rural population. And again, there are these numbers on the map. So those numbers are basically the percentages of rural population who got the opt-in option in their portal. Okay. In the next slide, again, the left-hand side map is the same one. The right side is PCP, primary care providers, whether they are getting that option from their primary care providers or not. So you can see that this West, North, Central, they have quite high number or percentage. They got that option from their PCPs. Okay, in the next slide, we just consider, or we just took CVD, cardiovascular disease, just to compare that if they have this chronic disease, whether or what is the difference, or what is the variation in percentages to get that opt-in option. Okay, so in the next slide, obviously the left hand side is for female, the right hand side is for male, and this is whether the population is from urban area or rural area. The red ones are basically from the big metropolitan cities, and this the last one from at the very right side, that is the blue one, is from urban area. So you can notice that the female who are in the rural area, they are getting that, they're like, many of them are actually like, there is a difference, and they are not getting that option to choose whether to see the test results before the clinician, before the discussion with the clinician. Okay. So the next one is, again, we are considering the region versus the disease. Again, we considered the CVD, cardiovascular disease, and we can see that this is the presentation, and when there is no disease, there is no CVD, then there is a gap between the like the large metropolitan people, large metropolitan population, and the the rural population. This is the presentation of patient empowerment by race and gender. So from left to right, the first one is the white, and second one is African American. The third one, or the middle one, is the Hispanic. The next one is the Asian, and the last one is rest of the other people. So we can notice that the difference for the Hispanic people, the difference in like male and female who got that option, is more for the Hispanic people. Okay, so this is again the male and female who have the cardiovascular disease, and we can see, interestingly, that the female population who doesn't have that disease, they are provided, like they are not provided, many of them are not provided with that option. So there is a gap between male and female if they are not diagnosed with that CVD. Now, the gap is much more less when they have the CVD. So we are trying to find our question, or we are trying to find like whether the presence of the disease is masking the gender disparity or not. Maybe there is the presence of this disease is there, so maybe that is masking the gender disparity. That's why we can see when there is no disease, there is a gap between the male and female population. Okay, so this is about the provider and gender chart or presentation. So PCP only 0 means whether they are getting where PCP only 1 means whether they are getting from their primary care provider. The option is from their primary care provider or not. And then in the right side, you can see that online portal PCP1 and online portal PCP2. PCP2 means they didn't get any access to the test results from their PCP. They're getting the access to their test results maybe from the lab, from anyone, but not from their primary care providers. And for that, you can see male and female gap is like more. Okay, so that was the first question when they provided that option. So I'm going back to the question slide. So far I was discussing the first question where the patients were given the option to decide whether they want to receive the test results before healthcare provider. Now I'm going to discuss the outcome from the analysis of the second one and the third one, which are nested. So if they provide that option, whether they looked at the test result or not. So going to the next one, and here is the presentation. So patient engagement by characteristics. So here first I'll start with the age group. So there are 5 age groups. So I can remember the first one, the red one, that is the age group between 18 to 35, and it goes up to this purple one. The purple one is 75 plus 75, so more than 75 years of age. So actually I cannot remember the division of this age groups in between, but obviously it is very important. You can see that it is gradually decreasing. That means the older people, they do have the access to their test results because they saw like there is no clinician's intervention, or clinician didn't tell anything, explain anything, there is no note. They even didn't view that one. So they didn't view that one, the 75 years old or 75 years age or older. Male and female is like they view the test results less. And then educational background, that is also important. So we can see the first one is the high school people, and then the level of education is increasing. And as the level of education increasing, we can see that the population is viewing those results more and more. And this one is this presentation is based on the geographic region, whether it is a non-metro, no-met means non-metro, or the population is more than or less than 19K. More presentation with race and ethnicity. So again, the first one, the red one, is with the white people, then African American, and the green one is the Hispanic. Then the blue one is the Asians, and the purple one is rest of the other people. So we can see significantly that this Hispanic population, even though they are given the access to the test results, they didn't view it. So this is about the next one here. This is about the marital status. So first one, the raised one, is the married couple. So they look at their test results more, but not the other groups. So the other groups, maybe they're separated. The blue one is they stay single. So this is the presentation of based on the population's marital status. The next one is number of adults in the household. So the red one means only a single person in the household, and the green means maybe 2 to 3%, blue means 4 to 9%. But we can notice those people who stay alone in a single household, or if they are staying alone, they are not viewing at the test results. Okay, the last question is whether they were able to understand, whether the patients, they were able to understand after those who looked at the test results, whether they were able to understand the result or not. So in the first slide, we presented the stratified mean for based on the geographic region, the rural and urban. So the first one is the metropolitan city, and then the mid-sized town and then the rural area. And for your information, the higher number indicates here the higher number indicates that they poorly interpreted the result. So if they poorly interpreted the result, then it is the higher number. So we can see that those who are in the rural area, this color, the gray color, so they were not able to understand the test result. Age, this is the presentation of age, again starting from 18 to 35 and then going up to 75. And then the stratified mean for male and female, and then with the educational background, again, we can see that the bar or the number is higher for those who are just high school pass out. With the more education, the number is going down. So again, for your information, this one, the green one, are those people who are who went to the high school, and then the other population represents with more educational, higher educational background. Okay, here is the presentation of race, and again for depending, here is the result presented depending on the marital status. So again, the first one is people, the green one are the people or the population who are single, so they are not able to interpret the result or they are like didn't understand the result. And based on the household, again, based on the household, again, this one, the green one, this is for single person, and then 2 to 3% and 4 to 9%. So if it is a single person, you can see the number is higher. That means they were not able to interpret the result correctly. So we also have kept some graph, some data presentation based on the geographic region. And again, this green one, which is the New England region, they have the lowest, and this pink one, which is maybe West North Central, they have the highest. That means they were not able to understand the test result. Okay, so next one, from next slides, Dr. Bashak is going to explain and present the next slides.
Thank you very much. Right now I'm at the hospital desk, so I don't have a computer, but I'm just still using my phone to turn the camera on. So so we already discussed about the univariate analysis. Most cases it was univariable models, but in some cases we did domain analysis and also a little bit of interaction model, and we saw some these graphs by stratified means or stratified percentage. So next we move to multivariable regression. These are all logistic regression, and this is from a complex survey design. So we also take into account of those design features, and we run logistic regression. So you see the upper box, the number of variables, like so this is about the first question, first objective, that is whether they are provided the opt-in option. They could answer yes, so you model yes. And it's a binary logistic regression, and these are the number of variables that we entered into the model: this frequency of health service use, education, gender, and so on and so forth. There are some strong predictors, but not many, not all of them. We do see age is a good predictor. Basically, my apology, age I think is negative. I should have been. So what I did is all those green one back, like green highlights indicates that they have a statistically significant association, and and yellow one says that they're marginal only. And oops, next slide. And the rating is negative relationship. So age actually is a typo. I'm sorry about that, but age is negative relationship. So the age goes up, your likelihood of saying that your provided opt-in goes down. Again, more interestingly, we do also see interactions by locality and provider type. For example, like which providers you get it from. For example, like portal one, when it comes from lab, uh, a patient more likely to say that they were given opt-in options. But this is not just simple. It's still there is some locality, rural, urban, by provider type interactions. Also, patients when said they got this portal access from multiple providers, I mean, basically they were given an options, okay, which providers you got it from, primary care provider, dentist, hospital, lab, and a bunch of others. So they could choose more than one. In one of the prior slides, you saw that some patients got only from primary care provider versus other. So in this particular case, when they said that they get the access from multiple providers, they're more likely to saying they got opt-in options. But important thing is that there's still regional difference, and these differences are like this by census division region, and this difference is not simple. Like if you see the overall effect, that's not there, but if you just deep down, you see there are subtle differences across regions. So that's one thing to note. And this is what we saw in univariable models, but also in multivariable regression. So it's possible that there's some sort of implicit customization or patient-centeredness things are happening, but that's not the end of all. It seems like there are subtle disparities in terms of providing opt-in options, and that must be taken into account and investigated further. Next slide, please. So the next question is the patient engagement, whether they look up the result before their physicians. So again, here we see a lot of predictors, and one thing this kind of like a strike a chord with the traditional disparity, the traditional shades of disparity in healthcare access or healthcare use, or even health technology use. So there are both systems levels and individual levels predictors, and in some cases there are some interaction as well. Like we still do see male by census region interaction. So there are some still. We talked about the disparity by gender. It seems it still prevails, and there are subtle differences across regions. For example, like mountain versus mid-Atlantic region, et cetera, and so on and so forth. So overall, the story is, yes, there are individual level predictors, and there are some system level predictors also, like census region, et cetera. These disparities still prevail. Next slide, please. So the next question is of patient literacy. Here we model the individual attributes to predict the ease of understanding. However, most interesting thing is that promise isolation scale, which indicates that the state of isolations patients believe that they are in, and that is strongly associated with the level of understanding. Again, age is negatively related. When patients have more ability, they said, okay, they can understand it. But surprisingly, what is interesting thing is that education doesn't stick on. So education is not really a significant predictor anymore, but others do. But overall, patients do struggle with interpretation. Next slide. So this is an additional thing that hints also ask about general understanding about medical records. Like they ask whether did you understand your online medical records. So it's again a 4-point scale, similar to one that we just analyzed. And is also like higher is more difficulty. And we do see an interesting thing. The graph says patient who said that could not really had difficulty in understanding their medical records. They also say that they were provided less frequently this opt-in option. But who said that easy, they are more. So it's about like almost like 7-8 percentage point difference. So this is not directly related to these opt-in questions, but it's just a general thing. So what it says that probably there is some implicit moderation by understanding, means like providers probably making an assessment or whatever other assessment, that's kind of like playing a role into this opt-in information. So and we do see that education is not a predictor. So that's a kind of traditional debate that literacy versus health literacy. Literacy is not often a good predictor of health literacy, and that's what we also see here. And at the same time, there's probably that there's some implicit bias or implicit assessment is going on in terms of providing this access.
Okay, so our final thoughts. So system level characteristics, we saw that they do influence in large percentage not being offered opt-in. So looking at the results and understandings are interestingly not driven by common source of disparity that you can find in many of the prior, or like many of the prior studies. There is a race, obviously, and social. Instead of that, social isolation and self-efficacy turned out to be important predictors, and harm and patient autonomy need more thoughtful balancing, because patient autonomy is important, and at the same time we need to the providers also need to think about the patient's harm, how to balance, as I was talking about, the autonomy, transparency in patient, and transparency in system, and patient empowerment. Okay, that's all.
Thank you. We've got one question in the chat. I'm also querying my students to see if they have any, but let's start here. Deborah Swain posed this question, and it anticipates a lot of my thinking. Do you think patient understanding and empowerment, autonomy, and legality will be impacted by artificial intelligence or the use of ChatGPT type tools? She complements this interesting research, especially on gender impact. But can you talk about the potential role of AI in this space?
Yeah, sure. Thank you so much, Deborah, for your question. And this is like very contextual question. So yes, AI obviously can be used kind of, if I don't say like the ChatGPT or generic AI tools are good for the patients, because they provide us good informations, but sometimes we cannot guarantee, as of now, the research they cannot guarantee like all the information are right. But if the providers, they can incorporate some AI tools with their platform, that may be more helpful. So instead of accepting, or instead of using by the patients, instead of using something already available to us, whether it is ChatGPT or Gemini or whatever Copilot that we have, instead of that, if there is some control, like if the portal or if the healthcare provider, they have their own AI tools and they can integrate that AI tools with that portal, and provide some sort of explanations, because we know like physicians are busy and this is burdensome and they may not provide timely response. So yes, AI can obviously be used But again, after some testing, after some research and going through some, pilot studies, this can be integrated with the portal system.
So
Thank you.
Mhm.
you reported also that households with more people, married people, and some other individuals tend to have better understanding. And is it safe to infer that we're not just talking about the patient anymore? That the patient is looking at the screen and they're turning to their partner, their child, their parent, and they're saying, I don't really understand this. You have this condition, what does this reading mean? Is that a safe inference to make when looking at your results?
Actually, these days you cannot just, control the patients from where they are getting the information. So if it is like the household, maybe there may be the other family members, or sometimes maybe from the friends, I don't know, but we don't have control on that. But it's just like we are presenting what the data is showing. But there is more to do, I know that, but it's like whatever we got from the hints data.
So on top of that, what we should also notice that we definitely have optimism, and optimism is good, it's contagious. But at the same time, we see the traditional finding that, okay, people who are isolated, they have always challenges, and healthcare is a special thing. And normally in those shades of disparity still prevailing here. So whenever we're providing access or implementing something, we should give a deeper thought. It's just like, okay, just let it go, do it. So this patient-centeredness, customization, and autonomy, it should have more balancing, more thoughtful implementation. That's what the result says. Because you can still have a tool, but people do misunderstand. And if you do, they have a price. So that's where the balancing and thoughtful approach is warranted.
Okay. Let me pose a very simple and straightforward question. One of the things you noted was the level of engagement and understanding by people who were identified as Hispanic. Is there anything in the data that looks at the language used by these portals when patients come to look at their test results and other information?
As far as I know, there is no qualitative information, but we have not really looked at it. First of all, that's a good question. We have not really looked at that particular language barrier. There may be some questions directly or indirectly we can still look at, but that's a possibility, but we have not really looked at. But think about the other way. The surprising, even some people who have traditionally college degrees, they also said that, okay, there's understanding difficulty there. So it's not just the language itself, but you should have that level of health literacy to understand it. So that was kind of a surprising element, because this is cliche. We all know that, okay, this language barrier probably is a big access barrier that creates, but this is not the end of all stories, because you still see that some people who are traditionally educated but still have some difficulty.
So are you kind of looked at these various factors one by one? Have you already done or plan to do a multifactorial approach where you can balance level of education, self-efficacy, social isolation to be able to essentially understand the contribution of that attribute into things like engagement and understanding, patient understanding?
So two ways. To your question, we did run some of these results that I presented, a multivariable model. So all those equations that you see, even particularly education, those effects are adjusted for. So whatever you see, the additional effects are there or not there. At the same time, we also produce some domain analysis, means like we run the analysis with particular segments. Say, for example, like rural people. So, and we tried to estimate that. So yes, we did some of this analysis, and some of these effects are standalone or adjusted for.
Okay, and a final, very simple question. It would suggest that some of the differences between urban and rural areas may be attributable merely to accessibility, bandwidth, and the difficulty of using a patient portal, because they do tend to require fairly wide bandwidth in terms of the data communication. Do you think that is a factor that may help understand that difference as well?
Possible. We have not really analyzed that directly, but it's not impossible. We cannot really rule that out. But many of them, at least large majority of them, use this portal, and some of them access through your web or telephone, smartphone, etc. So what the point that you're bringing up is important. That's a possibility, but that's not the whole story, I believe. There is some structural inbuilt disparity that's still there, and we should rather root that out.
All right. Well, thank you very much for a very interesting presentation. We appreciate the work you're doing, and we'll look forward to the publication of your results in the future. And we'll see everyone next week.
Thank you so much.
Thank you.
Mhm.
Thank you.
Bye-bye. Have a nice day.
Bye-bye.
Thank you.